Welcome to day one of the Canadian Nurses Association Third National Summit on Racism in Healthcare and Nursing. My name is Valerie Gardisa. I'm the CEO of CNA, and I'm grateful to be here with all of you today for this very important summit. As we gather for the third anti-racism summit, I want to take a moment to acknowledge the importance of this space and the privilege I hold in hosting this summit as a white woman of settler origin and beneficiary of colonization. I recognize that my identity comes with a history and presence of systemic inequities that impact the experiences of many in this room and in our broader society. I recognize that hosting an anti-racism summit as someone who benefits from the systems of privilege requires humility, listening, and a commitment to creating meaningful change, and I will do my best to embody those attributes on my journey as an ally. I am here not as a voice of authority or experience on the lived realities of racism, but as an ally, learning alongside all of you and implementing these learnings into my leadership position to advocate for systemic change in the Canadian nursing landscape. Together, I hope we can amplify the voices of those most impacted by racism and work towards building a more equitable and just healthcare system. Thank you for allowing me to be part of this important dialogue. I would like to start by saying thank you to TD Insurance for sponsoring this important event. Before our opening remarks, I would like to run through a few housekeeping items. Please use the Q&A function on Zoom for all technical support questions. A CNA staff member will attempt to respond as soon as possible. If you have questions or comments about the content of the summit, we will be using the platform Mentimeter to engage with you throughout the sessions today. You can participate by scanning the QR code or typing in the PIN number on the top of each slide. Please follow along with the questions in the order of the summit instead of skipping ahead so we can see your responses in real time. Both summit days have a French stream, which you can access from the bottom of your Zoom bar to access translated live audio and captions. Also, to note, today's session will be recorded and available for access at a later date on CNA's website. Lastly, I want to acknowledge this can be a difficult day and the content may bring up difficult feelings or memories. We encourage you to step away as needed and please access as needed mental health resources, which are also posted on the CNA Zoom event page. I just wanted to move forward with the CNA land acknowledgement. In Canada, we live, learn, and work on traditional Indigenous territories. We are also direct beneficiaries of policies of expulsion and assimilation of Indigenous peoples during and since the time of settlement and confederation. CNA acknowledges that the land upon which each of us is joining this meeting is and continues to be the home of diverse First Nations, Inuit, and Métis people. This acknowledgement is made with the recognition that nurses have a responsibility to learn the harsh and devastating impact that colonization has had on Indigenous peoples, past and present. We have a duty to respond to the calls to action of the Truth and Reconciliation Commission of Canada. And I'm delighted now to introduce Lisa Techrobe and Deanne Shepard from CNA Indigenous Relations Action Council to give the land welcome.
Oui, bonjour, hola, ni hao, assalamu alaikum, tansi, namaste, hello. Neen DeLuisi, Deanne Shepherd, Delawe, Dachenbrook, Wigi, Bridgewater, Nova Scotia, Akbijanisqua. My name is Deanne Shepherd, and I am from what loosely translates as the land across the waters, now known as Newfoundland and Labrador. Today, I am south of Bridgewater on the western shores of Bijanisqua, the La Have River. It is my pleasure today to welcome you standing at the eastern door, my feet firmly planted on the unceded territory of the Mi'kmaq, the land of the people of the dawn, of First Light, and the Wabanaki Confederacy. In my territory, we live the Peace and Friendship Treaty. The eastern door is the direction of the sunrise, new beginnings, potential, the direction of fire, the direction of eagle, red-tailed hawk, and cardinal. On behalf of the land, all of our kin, and the Indigenous Action Council, I hope you will respect this welcome and the responsibility of nursing and each one of us to commit to the important work ahead. Imsit Nogama, Akwalaliok, love and gratitude, all my relations. I now pass the feather to Lisa.
Thank you. Hanse Tawao, Lisa, Gasan, Igwa Dalmani, Saskatchewan, Treaty 6, so it's Nia. That was hard for me to do because I'm reclaiming culture. So in that, I sat in prayer today and what I wanted to say in my welcome. I thank the traditional knowledge keepers and elders who have guided me here today to welcome you all to this very important event. What I was taught is that we don't own the land, we're borrowing it from our future generations. And I'm so excited and look forward to this workshop. On behalf of my ancestors here from Treaty 6, the homelands of meeting grounds and gathering places of the Cree, Dene, Soto, Nakota, Lakota, I welcome you. And it's hard for me to do a welcome on this virtual Zoom. I'm so used to inviting people in and saying, Tawao, Pitagwe, come in. You're all welcome and have some tea. So thank you. I look forward to this meeting, this journey with you. And from my heart and from my ancestors, you are all welcome. Thank you.
Thank you, Lisa Tetrobe and Deanne Shepherd, for the beautiful welcome to the land. We are so grateful and honored to have you with us today. I would like now to hand over to Dr. Lee Chapman, Canada's Chief Nursing Officer, to provide opening remarks for day one of the Anti-Racism Summit. Over to you, Lee.
Thank you so much. Merci beaucoup and bonjour tout le monde. I'm really delighted to be here and really want to thank Lisa and Deanne for that very warm welcome in ensuring that we are starting in a good way. And really, really pleased to help kick off the third National Anti-Racism Summit. I really want to say that this is a pressing issue for nurses across the country. Certainly, we have many examples of work that is needed to be done in this area, and that's why we highlighted not just the need for anti-racist and oppression as sort of the guiding values underlying the nursing retention toolkit, but also highlighted the Nursing Declaration Against Anti-Black Racism in Nursing and Healthcare under the theme of organizational mental health and wellness supports in the Nursing Retention Toolkit. We also know that anti-Indigenous racism is a significant issue. And, you know, there's examples of this in Canada with Joyce Echaquan, with Brian Sinclair. There's many examples of, you know, work that needs to be done in this area. And so I'm really pleased to also mention that we are developing a companion guide to the Nursing Retention Toolkit. It will be an Indigenous companion guide to really hover and center nursing Indigenous nurses recruitment and retention, and focus on the pressing issues that actually impede Indigenous nurses from entering our nursing workforce. In all of my work over the last 2 years, I've been really pleased to work with Indigenous nurses, the Indigenous nursing research chairs. I know some of whom are here today are doing exceptional work, and really great capacity building work with their trainees and students and communities across the country. I've also had the privilege of working with the Canadian Black Nurses Alliance, with the Pan-Canadian Association of Nurses of African Descent and other equity-deserving groups. So I've really tried to foreground this work in my role as a white settler in occupying the federal chief nursing officer role. I'm so privileged to be here and to know that there are so many of you from across the country, almost 500 nurses. I know there's been a lot of decolonizing work underway in nursing education, a lot led by the Canadian Association Schools of Nursing, and the Canadian Nursing Students Association, and really applaud those efforts. Sorry, it's showing my internet connection is unstable here for a moment. So hopefully you can still hear me. You can still hear me. Okay. But I really applaud CNA as our National Nursing Association in hosting this. You will be hearing from the leading experts on the topic of anti-racism across Canada over the next afternoon today and afternoon tomorrow. I'll be pleased to be participating tomorrow. I'm in transit today, but it's not for lack of interest. I will be with you in spirit today. And I will just say that, in my dialogue with our colleagues internationally, there's a lot of work underway in this area in the nursing community. So the NHS in the UK had actually implemented a standard on anti-Black racism across the entirety of their health system. Of course, they have a nationalized health system, but this was in the wake of the death of George Floyd. And so I think, this is such an important topic. I'm pleased that nurses are leaning into this because there's no shortage of work in this area. And I think that because of our relational practice, because of our attunement to social determinants and equity, we have a key role to play when it comes to anti-racism, and especially around evidence. So really, really pleased that you're all here. Pleased to kick off the event. Un gros merci to CNA for hosting, and I'm sure it will be a wonderful dialogue and look forward to seeing you all again tomorrow. Thank you so much. Merci beaucoup tout le monde.
Thank you, Lee, and thank you for your leadership and bringing nurses and leaders together on this critical discussion. Really appreciate it, and thank you for being here today as well. So it's so wonderful to have all of you here, and we just again want to thank you for coming from across Canada and internationally, and to the CNA staff that have been contributing to the event, the Anti-Racism Action Council, and the Indigenous Relations Action Council, and the Anti-Racism Summit Steering Committee members. Bringing together all of you has been an incredible effort, and we just want to thank everybody for your contributions, and we look forward to the next 2 afternoons. So it's my delight to introduce Dr. Josephine Etowa, our keynote speaker. Dr. Etawa's research focuses on inequities in health and healthcare, with emphasis on nurses' work life, community health nursing, and the health of African, Caribbean, and Black Canadians. Her research studies are informed by an intersectionality lens and community-based participatory research approach. Her employment history spans across international boundaries, and as a registered nurse, a midwife, a lactation consultant, a researcher, and an educator, Dr. Etowa has worked in various capacities within the Canadian healthcare system. She is a transformational leader in health equity, anti-racism, and community empowerment research within Canada and internationally. We now welcome the esteemed Dr. Josephine Etowa, who will speak about how to implement or promote the implementation of anti-racism policy implementation in different nursing settings. Over to you, Josephine.
Event to move within our profession forward. I am also delighted to see so many nurses across the country, nearly 500. And also would like to thank Dr. Lee Chapman for the work she's doing to address this work, and also the many nursing organizations that are now engaged in this kind of equity work. I think it's really an exciting time for nursing to be involved and actually leading some of this work. So thank you for the opportunity to speak at this event today. I know in the last two events, the Anti-Racism Summit, we've talked about racism and the various manifestations of racism. And today we're moving that work to actually doing something, implementing programs to address racism. But I just want to start with a little bit of context. And actually also to add that as of yesterday's official, I do have a different title, Canada Research Chair Tier 1 in Advancing Black Women's Health. That is a Social Sciences and Humanity Council funded research chair, was announced by the minister yesterday. And so that's the new agenda moving forward for a national program to address Black women's health. Next slide, please. And so in terms of the context of this work, I just want to again remind us why it's so important for us to talk about racism in nursing and in healthcare as a whole. So the social determinants, including the structural inequities, are known to account for the disproportionate health risk and differential health outcomes experienced by racialized people in Canada. So the BIPOC people, Indigenous, First Nation, Inuit, Métis people, African, Caribbean, and Black people. And I often like to use that ACB to ensure a more inclusive lens to include Africans from the continent, Black people from the Caribbean, and Black people that have been in the Western world for multiple generations, including African Nova Scotians, and other people of color, of course, in Canada. So the various forms of discrimination intersect, and multiple forms of racism of discrimination then affects what we see in a different healthcare setting. And it's important for us to think about this because as we implement program, we begin to look at our different healthcare settings to see how some of these issues are manifested. There's substantive evidence that demonstrates that racism is a central determinant of health and actually a structural determinant of health and the well-being of racialized individuals, families, communities, and even nations across the world when we look at the different statistics we have. It has been a persistent problem in terms of not just the manifestations of disease and pathophysiology around disease conditions in people's body, but also the delivery of services. That's where concerns us even the most as nurses and access to those services. Public Health Agency has declared, shown that the health of Black Canadians, the outcomes of Black Canadian health is disproportionately poorer than that of their white counterpart, even though they may even report positive health behaviors. And we also have a number of studies. The UN declares Black Canadians of African descent that continue to face poor health outcomes related to systemic anti-Black racism. So these issues have been named, and now it's for us to address it. Next slide, please. I just wanted to use one area, HIV, to illustrate the point of the stark differences we see. Over the last 4 years, I spent my time as a research chair funded by Ontario HIV Treatment Network to address HIV among Black women. And for this particular one, and we can go on to name other issues, including mental health, perinatal mental health, and fibroids, other issues, and you will see disproportionate burden of these different diseases among this population. So although African, Caribbean, and Black people account for only 3.5% or under 5% of the Canadian population, they are grossly overrepresented in terms of HIV cases with known race and ethnicity. And I said known race and ethnicity because not every province is systematically collecting data on race, even now, to actually be able to say this is exactly what the numbers are. But even for those that are collecting, the ACB women make up, this is Ontario data. The Ontario has the OHC data set where they collect data on this. ACB women make up 42% of new cases among women in 2019 and 19.6% of the new cases in 2020. So you can see for a population that make up less than 5% of the population, consistently over the last 10 years, this population carries a quarter of the burden of HIV disease, about 25%. And when you look at women in particular, you can see the significant difference there. And when you look at that Ontario data further, you can see there, even in Ontario, ACB people make up 4.5% of its population. But again, for the known race and ethnicity cases, ACB women comprise 59%, more than half of the first-time diagnosis among women in 2019, and 44.4% of first-time diagnosis among women in 2020. This is followed by white women at 31.5% and by Indigenous women at 13%. That is the Ontario data. So this just tells you the significant difference and work that is needed in some of these communities to begin to address this, whether it's from the point of racial health literacy and other issues of access to the right information to change these numbers. And what's interesting is, even with this high number, when you talk about diagnosis and treatment in terms of meeting the UN indicators to advance HIV work across the world, and even in Canada, to the 90-90-90 rule, like 90% of the population would have been tested for HIV. Those who are at risk will be tested. 90% of those, now we've moved that to 95. 95% of those that are tested would know their status would be on treatment, and 95% of those who are on treatment will have viral load suppression. And we know U equals U. Undetectable viral load means untransmittable. But if populations like the Black community are not getting tested, don't know their status, then that indicator, we're not meeting it. In Canada, we're already meeting indicator 1 and 2, except for certain population, including the Black population, that is actually most affected. So it's really an issue that illustrates some of the systemic barriers we're talking about. Next slide, please. And so what does racism have to do with this? Again, we know it is deeply embedded in guidelines, in practices, in policies, and the beliefs and attitude that produce or condone or perpetuate that unfair treatment of racialized people at multiple levels then affects how they live and maintain well-being, and how the social determinants then combine to amplify those systemic threats to health, then rendering some people more vulnerable to both physical and mental health. And I just like to use this diagram to illustrate the whole idea of the multiple level. So when we're talking about policies and intervention, we have to ensure that we're using a lens or a framework that captures these multiple levels of the issues, whether it's at the systemic level, at the institutional level, at the interpersonal level, at that individual within us level, where we internalize the things we're hearing, and it begins to drive our, even those of us, or say those who are racialized, begin to internalize this and further compromise the work that needs to happen in the different systems. Next slide, please. I was trying to change the slide myself. Another point I think I like to mention around racism is this whole idea of epistemic racism. Because in nursing, we haven't talked about this. Over the decades, over the years I've been doing work in this field, I find it's easier for us to talk about racism as it affects the patients. But racism as it affects us as colleagues working side by side is often not given enough attention. And so epistemic racism is one of the patterns or themes that have come out of one of my recent studies that we cited there in 2021, where epistemic racism refers to the knowledge systems and rules about what we can know and what is known. So the epistemology and both the ontology, what we know, what we value as knowledge. The ways of knowing are considered valued. Who can be legitimate and authoritative knower? And so these knowledge rules are often implicit. They are not written in our textbooks. Whose voices and knowledge claims are privileged in nursing scholarship and nursing leadership? Whose knowledge would be pulled to the stage or advanced? Those are key in terms of the ideology, which is the real anchor of the systemic racism we're talking about. When we're talking about structural racism, epistemic racism really means knowing all knowers, if we can get to that, on that, valuing all of us. So building an inclusive and healthcare, inclusive nursing and healthcare requires that the knowledge claims upon which our professional authority is granted be extended to all kinds of knowers, all colors of knowers. We become more conscious of the opinions and attitude everyone brings into the marketplace of nursing and the ways in which our mindsets affect our behaviors, our individual differences, how we value that, and how each person feels included, respected, and fairly treated. That is a piece of the work that is often not given enough attention. Next slide, please. And so moving forward with anti-racism work in nursing, over the past 5 years, there have been an increase in effort to address racism and increase equity in healthcare through professional education, clinical practice, research, policy, leadership. We are seeing EDI policies call different names. So progress is being made in terms of the creation and implementation of anti-racism and EDI policies in the areas of health and nursing research, education, clinical practice, leadership, and the workforce. However, there remain significant challenges to transforming nursing care in terms of tackling the structural racism as a key determinant of health inequities. The ways in which racism is conceptualized and articulated in policy interventions are directly related to how that shape the implementation and effectiveness of policy tools that are employed. Because if we articulate racism as those differences or disparities in health and healthcare, where we're going to design things that fix that policies or that fix the problems the way we define it. Next slide, please. So given that racial health inequities are also created by allostatic load pathways, that is where the body's experiences of cumulative chronic stress over time leads to various alternating gene expressions and disease. Nursing research and practice need to focus on both the disease and its root causes. If you look at fibroids, for example, uterine fibroids, and I point to that because 2 weeks ago, on the 7th, I just lost a dear friend here in Ottawa because of fibroids, uterine fibroid complications, young in her early 50s. So considerable literature on uterine fibroids examines biological factors such as gene polymorphism, gene density, gene expression, which shows higher prevalence among Black women. However, there is very limited research that goes upstream to examine the structural determinants that may be contributing to these genetic alterations. We tend to focus on the disease without situating the disease within the context. So until we begin to examine the context creating these kinds of disease, we see then our policies may be limited to just addressing this disease, possibly providing more access for more surgeries without addressing the bigger root causes of these issues. So nursing research needs to conceptualize disease such as HIV, such as fibroid, not as discrete and bounded entities, but in terms of their interrelationship with harmful social conditions and relationships with our environment, our workplaces, and the stress that brings to people's life and the changes it creates in both mental health and the physical health. So the structural rootlessness of racism calls for actions on racialized health inequities in a manner that accounts for systems of power that undermine fair access to resources and opportunities to achieve optimal health for racialized people. And I must say, I am hopeful because we see work happening. Recently, I believe last month, October, CIHR had a funding call that specifically said they're looking for research that moves upstream to address structural health inequities. I thought, wow, CIHR has this call. And so it's interesting because finally we've reached a point where we're speaking about the language of going upstream to begin to carry out research that articulates this, and hopefully we can move that upstream language to our clinical practice as well to think about policy interventions. Next slide, please. And so I think that effort to tackle racism require a comprehensive, multi-level, long-lasting approach anchored in evidence and the principles of social justice and equity. Modules like the critical sociological model, socio-ecological model. Why? Because it allows us to address these issues at multiple levels. Intersectionality that takes into account the critical intersections between our various social locations and social identities. Transformative approaches that create environment of empowerment for those impacted by the issues themselves. We need this kind of approaches not only in how we engage in research, but even how we design programs and policies in our various healthcare settings. So this allows us to bring in methodological innovations in ways we haven't done before, to recognize different ways of knowing and bringing all of those things to gather evidence to support innovation in policy interventions. So critical analysis of the pathways through which structural racism shapes health outcomes for racialized communities would then be designed based on these kinds of innovation. Equity-driven resource allocation in the areas of funding, workforce diversity, especially in leadership, in research, in data governance, and accountability measures in nursing would really need to use these kinds of framework to look at it. Next slide, please. Intersectionality, I just wanted to, again, show how we have to take into account the social determinants of health and the multiple social locations that create those critical intersections that we must look at in our work and in our policy implementation. Intersectionality is one way to guide our anti-racism policy development and implementation, and it also facilitates interpretation and communication about how these social identities really intersect to compromise health outcomes. Next slide, please. I like to use this iceberg model to really illustrate the whole idea that if we carry out any policies, guidelines that address the things on the surface, what just happened? Microaggression, stereotypes, invalidation, discrimination that may happen at the surface level, that we need to tackle the deeper issues in the dark area of this iceberg, because you can see that the multiple prong approach is necessary for change at multiple levels. While behavioral approaches address individual thinking and behavior, system thinking and approaches are necessary to change the structures that determines these health inequities, including our ideology, color blindness, white supremacy. Can you see those? Those values are deep-rooted right at the last layer there. Quite often our interventions ignores that piece. And we have to think about those values. White silence, white apathy. How do we think about issues that, oh, well, I'm too busy, I'm too busy to address that. I'll leave that for the people, being the bystander that wait for other people to do the work. What's the role of allyship? And we'll be talking about that. How does that play a role in supporting those leading the work? Those are all things that need to move through these different levels. So frameworks like this help us to make sure we have a multiple-pronged approach when we're designing our policy intervention, and to make sure there are multiple voices capturing these issues at the table. Next slide, please. I wanted to illustrate how the participatory approach, which is a transformative approach, really gets implemented. And the diagram I have there is actually a diagram of one of my research projects to illustrate how we actually use this in research. You can see this is one of the COVID projects I did, advancing healthcare for COVID-19. And this is targeting providers, strengthening provider capacity for best practices. In the design of the study itself, we're starting at those multiple levels. You can see how the same model, the socio-ecological model, is used to guide even our research questions, the questionnaires we're using. We pick questionnaires to capture the knowledge, attitude, and tools at the individual level. We pick a questionnaire to capture community-level interventions or issues. We pick questionnaire to capture institutional and provider perspective on the issue, and also questionnaires that would address issues at the broader systemic and structural level. And those questions then ensures that our findings capture issues at multiple levels. And so when we use community-based participatory research, it is not only an approach to an investigation, it is a means for mobilizing for collective social change, to address the community needs, and for creating change at multiple levels. And so when we talk about creating an environment of empowerment where transformation can take place, I informed that work with Paulo Freitas, the educator from Brazil, who wrote The Pedagogy of the Press. And central to his work is the idea that we have a responsibility to produce reality and to transform reality. And so for all of us, including those experiencing the issues, when you see a situation affecting you or others, you engage in analysis of the situation and you act to change it. And so CBPR is a way that you engage with the issue in terms of investigation. You carry out education that creates that critical consciousness raising to change the minds of those involved in the work. And it is that change that leads to action for change. Because when people are transformed, say, what? So for example, if I'm doing HIV work, as I present and speak with the team, you see community members saying, really? This is how much impact HIV has in our community. People want to do something about it. So change is happening as the research is being implemented. Next slide, please. So this is illustration of how we operationalize this, and this is actually an actual study. This is the vaccine project, AVA, ACB Vaccine Acceptance Project. You can see that right from the conception of the research, the community is at the center, the academic institution from above there comes in. We bring in other community organizations that work together with the community at the center in the co-design and implementation of this study. And we have an advisory group that continue to inform the project throughout. And once we have study findings, we bring it back to a community engagement forum, whether it's Action Summit or cafe event, to present the findings and get community input first before we move to the knowledge mobilization, where we begin to produce all the knowledge tools you can see at the end. And so this is for research, but we can do the same thing for policy and for practice guidelines. Next slide, please. Okay, removing the barriers. I just wanted to remind us that nursing is ideally positioned to take a responsibility for implementing anti-racism policies and practices. And quite often when we look at this, we need to reflect. I put this slide to get us to reflect. In your own workplace, what are the barriers that need to be removed? If you can think for a moment. And how can you move that barrier in your own workplace? Because quite often when we think about removing these barriers, we're looking at this equality. And I deliberately chose equity. If we focus on equality, we're talking of those differences. And you can see here, we see this, the little guy, we see the tall person, and we give all of them this tool. Many of us have seen this. And even if we decide to move to equity to say we give somebody what they need, when you give the tools here, we're still dealing with the individual problems. Give this one scholarship, give this one so many scholarship, and we would get there. But we're really aiming for more systemic change, where the big barrier that is blocking some people can be removed so that we have less of the individual tools, like the stool, giving one person two stool, one and the other one none. How can we remove the systemic barriers? So we should be aiming that our policy should be aiming to remove that systemic barriers so that we have a play level field where we can have people rising up in the profession, reaching leadership role without feeling like they need a special help to achieve that. Next slide, please. And I just thought I'd share this policy circle. This is a diagram actually from a public health agency of Canada. I've had a number of some of the speakers that will come to my policy course to speak at the University of Ottawa, talk about the policy circle. And I thought in nursing, even when we're starting doing policies, we need to think about how we bring the multiple voices. And in the case of racism or anti-racism policy, how we bring the racialized people right to the point, the starting point of this, even before we identify the issue. Look at the red arrow on top there, the values and beliefs. Our values and beliefs informs how we frame the issue. So even before we identify what the issue is, we need to bring people with their values and beliefs to see how we come together to recognize what we are really calling an issue, so that we can truly name the issue, the green arrow, well. And we also need to bring that multiple perspective in terms of the knowledge development and advancement of that issue, and how we raise public awareness of the issue, and the political engagement that is necessary, whether it's working with lobbyists and working with other groups that really brings about policy change, policy in the bigger public policy I'm talking about. But even in the smaller policies and guidelines in our institution, we need to think about the values driving how we frame that policy and who is missing at the table. And so citizenship activation, once we've been able to politically engage, whether it's talking with our MP and talking with other leaders that would buy the idea of the problem we have and to recognize it as a policy issue, I think in all stages of this, we need to ensure that we have the right people at the table, because as we say, nothing about us is for us without us. So if you're talking about racialized people and they are not at the table right from the beginning of this policy circle, then there's something already missing before we even get to the implementation of the policy. Next slide, please. And so moving forward with policy, racism is a complex process requiring interconnections of the various systems that holds it in place. We're talking the purpose or intentions of our intervention. We're talking the process of implementing those interventions. We're talking the people involved in that implementation, the place. Where are we implementing this? And the power. We need to talk about the power structures in our profession. So transformative anti-racism nursing interventions need to be anchored in policies that target these 5 systems. You can see, I like this diagram that is used here, because you can see the magnifying glass with the 5 P's. But it must work with the policies. Policy is a key part. One of the things, as I reflected upon this presentation, I look back over the years. For nearly 30 years, I've been talking about racism. And I've been, so the last 25 years, writing, researching, and doing work in this field. And I'm saying, and we're still identifying today the things I was writing about 25 years ago is still happening today. It can be discouraging, but I said now we have leaders, we have a shared language to talk about racism, because those days I don't think we could talk about it in this way. One of the things the pandemic has brought forth, the silver lining, or the pandemic and George Floyd's death, is that we all have a shared language. We can name racism for what it is. We can even acknowledge structural racism, that it exists, and we need to address it. Now we need to move upstream to talk about those structural barriers and how our policy interventions can actually get to that. And so I think that the 5 Ps can serve as a guiding principles to evaluate the impact of policies on well-being and attainment of health equity in both healthcare settings and in community settings as well. As nurses, we work in community settings, we're promoting health, and I think our policies need to capture both what's happening in the system itself, but also in our communities to prevent health. And you can see how this diagram really ties racism as a root cause to both the social factors that create the ill health, the psychological factors, and even the biological factors. Racism has impact on all that. So if we're addressing HIV, for example, we cannot take HIV and develop policy that doesn't touch on racism. Then we haven't gotten to the root cause of the problem. Next slide, please. So going upstream, this work is from the National Collaborating Center for the Determinants of Health. I think they're truly moving this work to that upstream level. Their current work is also addressing food security and other issues. They've talked about structural determinants, and I think it's so important for us to think about the political, economic, and social structure of society and the culture that informs them when we're doing this work, so that we can truly talk about the role of power processes in the creation and perpetuation of inequities in the distribution of the social determinants of health. Next slide, please. I just wanted to, it's a new systematic review done by Canadian researchers here, Hazan, that actually gave us a framework that we can use to make sure that we start with policy. See here, laying a foundation for anti-racism interventions in healthcare, and it's a Canadian piece. Again, it walks us through the policy circle that I just showed you in that diagram, showing us how to define the program with setting clear goals and objectives. And what I also like about this is how it tells us to work in terms of the socio-ecological model, addressing policy level, addressing organizational and community level, and also interpersonal and individual level interventions, targeting these multiple things happening concurrently, because one level or just one intervention does not completely address it. And of course, having monitoring and evaluation framework, accountability to see how the policies we're working on or the programs we're developing, how they're actually creating impact. Next slide, please. And again, this is an example of the systemic level, and I won't get into this, but you can see from that framework that we need to target system and policy level interventions and use frameworks like the socio-ecological model and intersectionality that I've mentioned there. We should target these different levels. Next slide, please. Organizational level deals with the structures and processes within an organization to effect change. So the organizational level policies that are necessary to address both organizational culture and individual level skills and attitude of providers, and also those that work in the system, how we demonstrate committed leadership in terms of addressing diversity. Quite often we're talking about EDI, but you can have an organizational statement that has nothing to do with EDI or doesn't mention that word. And so then when it's time to distribute resources, resources are allocated to those things that are captured as the mandate of that organization. And if equity, diversity, and inclusion is not a key aspect of that, then it doesn't get the resources it needs to be addressed. Well, many people are doing equity, diversity, and inclusion work. We need to know that diversity is the beginning. It's the first stage. When you're talking about representation, bringing in people, that is only the beginning of the work. Now we have to do more work to ensure inclusion. How do those people you have brought succeed in the same way as others? Or are they secluded and in some group there where you just stay below and never move up the career ladder? Then they haven't truly been nurtured and become included in terms of the EDI. Equity is really the peak, is where the pinnacle of the work we want to see, when we begin to see these differences in terms of accountability measure and looking at our leadership, what does it look like? If we've had all these EDI policies and we now recruited racialized people in our organization, but they're not doing better, they're not moving in their career in the same way the other people are moving in their career trajectory, would we call that success? We've done representation, but we haven't done inclusion, and the equity is not obvious yet. So we really need to look at how we're moving with those policy implementation. Next slide, please. And this is at the community level. This is to create intervention and maintain authentic community collaborations with racialized community people. So it's one thing to have our policies that address service provision, but we must also have interventions that are community facing, creating capacity building and mobilizing the community to engage with our services, to engage with the work we do as nurses in our multiple settings. Next slide, please. The interpersonal level, of course, one of the key elements of advancing this work is making sure that we nurses as providers have the capacity to provide this care effectively. And so it is an important part, whether it's training of healthcare providers, addressing privilege and implicit bias, and the different things that we need as community, as healthcare providers, to feel comfortable working effectively across racial boundaries. Next slide, please. Because the individual level, there are things that happen at the interpersonal level, but even within us, that implicit bias, unconscious bias, the training that we need to help us as individuals to have this reflective practice, that we can actually think about how we work, not just with our patients, but how we work with our colleagues who may be racialized. Next slide, please. I'm moving a bit faster so that we can have some time for questions. Effective implementation, these are some of the key areas of challenges. We need to understand that leadership and support, commitment of leadership is important. We need dedicated resources, including funding and other kinds of support, mentorship that will be necessary for people to have that, what they need, the capacity to work effectively across racial boundaries. Again, it's a multiple level intervention that's needed. And we must understand that one size does not fit all. Some people may benefit more from certain kinds of programming, and others would need something different. And so we need to think about these different interventions. Next slide, please. I wanted to share here at the Co-Create Lab, my research lab at the University of Ottawa, that is a collaborative critical research and equity and transformation in health research lab at the University of Ottawa. We've developed 2 programs. We've just finished implementing this CHRL, that is the Critical Health and Racial Literacy Program for providers working with African, Caribbean, and Black communities. The content of this course is also effective in working with other racialized groups. We offer that. We've been able to train nearly 200 providers, and we're using that. This is a CIHR project where we're now conducting a focus group and doing evaluations on that so we can see areas of refinement and modification. We've also had, so that's a provider or system-facing intervention, and we have another intervention that targets the community, that is the CRF for peer equity navigators. The 2 ladies sitting there are actually some of our peer equity navigators that worked in the community and go, we cover a number of topics, including the history of Black Canadians and anti-racism, cultural competence, and the social determinants of health and the pathways through which it impacts health. And we work with these peer equity navigators. We're just starting a new program that goes across Ontario to target HIV in particular. This particular one target vaccine uptake, and now we're working with HIV across Ontario. This is CIHR funded 5-year study. Next slide, please. This is the system-facing course. It's showing you the modules, the 5 modules there, the social determinants of health. And then we move specifically to address COVID. That project was funded through the COVID funding and address critical health literacy, critical racial literacy. You can see the modules of our intervention there. This course right now is free online to take the program. Next slide, please. This is the peer equity navigators that have been nicknamed here in the Ottawa area as the foot soldiers, the ACB foot soldiers at work, meeting people where they are, whether it's in their communities, at the mall, wherever they are. And it's interesting because these peer equity navigators, they made uniform for themselves without the team. Like, they literally made uniform for themselves. They are the peer equity navigators, the pens that are rewriting the story of equity in the Black community. And so we're so happy to work with them and take that to the next level and working with different disease issues. Next slide, please. We've been able to evaluate this program. We have the article for the evaluation program that is out now. Again, these foot soldiers address this. They have this knowledge that just motivates them to go beyond the life of our project. They continue to become advocates in their community and become change makers in the community, so that even after they finish the paid role within a project, they just continue the work. What was so interesting is I've talked about this program in some presentation, and I had community leaders, mainstream community organizations saying, "Oh, I want to hire a pen. How can I get a pen?" And so we have more placement now for community. We're training 30s coming up in January to be able to partner with different community organizations and help with that outreach that is necessary to get knowledge to the community. Next slide, please. So in conclusion, anti-racism interventions need to be multi-pronged and multi-sectorial. We need to have system-facing interventions that target institutions, professional organizations, nurses, and other providers and decision makers need to be our target. But we also need to have public or community-facing interventions that target our patients, our community leaders, those people who are gatekeepers, faith-based leaders that can carry this information to the community so that we can make sure that we have an educated and empowered community coming to the hospital and to our facilities so they have the right questions they can ask and advocate for their own health need. And so they can actually advocate for policies too to better fund some of our nursing interventions and nursing programs. And so training and health workforce development remain some of the key strategies to implementing anti-racism policies in nursing to improve health services and outcome. And nurses are well positioned to implement both system and community-facing policy and practice interventions. Thank you.
Thank you, Dr. Etowa, for starting off the summit with the most thought-provoking and wonderful keynote presentation with solutions that we should all be considering and implementing. And throughout the chat, you saw lots of great questions and ideas and/or strategies being implemented across the nation. I know you had mentioned taking some questions. There are some questions in the Zoom link. I don't know if you've had a chance to review them or if you'd like me to or someone to take your attention to them, and maybe there's a few that you'd like to respond to. In terms of, yeah, there's a few, or would you like me to just read out a couple for you just with the time we still have?
Sure. Why don't you do that?
Okay. So there is just from Claudette Holloway, just a recognition of RNA's Black Nurses Task Force report with the 22 recommendations. So thanks for sharing that and your commentary on that. That's very helpful. And we do know this is their strategies being implemented nationally.
Mm-hmm.
There's a comment here, not only focusing on the fence, but is everyone equipped, dressed warm enough in brackets to participate? Equate this to people's access to healthcare. Do you want to comment on that?
Everyone dressed. Can you repeat that?
So not only focusing on the fence, so that was your equity equality slide, but is everyone equipped and in brackets dressed warm enough to participate and equate this to people's access to healthcare?
Yes, absolutely. I think that I don't believe we're all equipped now because we're still collecting the data. From what I presented, you can see that even the way in which the questions are asked and the problems are defined affects how we can address it. So yes, we do need more work, but we can start where we are. We may not have all the answers, like many healthcare issues and policies. We may not have all the answers, but I think we are equipped to start the discussion, to start somewhere and work with somebody who maybe have more data as we continue to collect more data to inform our work.
Thank you, Josephine. That's wonderful. And that again was, sorry, I had to move my screen. It was from Marcia Glasgow, just so you know who asked the question. The next question is from Angie Saney, and she says, I feel like we are experiencing a backlash against DEI right now, and I feel it has become a political issue. I'm concerned about the impact of this on advancing health equity. How can we challenge and overcome this?
That's a very, very important question. Because we just started the work. We only started really actively engaging with this work. And I think we're having the backlash, like you said. But I must say that we have to stay focused and continue to educate our colleagues, our friends, others that may not fully understand the issue. Because I think when we say Black Lives Matters, for example, or we talk about focusing on a particular issue that needs to be addressed, it does not mean that we neglect the other issues. It does not mean that we neglect other healthcare issues. It just means we pay attention to address this issue as well, right? And so we need to educate our colleagues. We need to continue to take risk and stay focused on the job.
Great. Thank you, Josephine. There's several just thank yous and commenting on the excellent presentation, but the next one is from Gabriel Domacos. Sorry if I got that wrong. Is the healthcare system as it is currently constructed with colonial, military, and now neoliberal logic compatible with the elimination of racism?
So I got distracted there.
Okay, I'll do that again. Is the healthcare system as it is currently constructed with colonial, military, and now neoliberal logic compatible with the elimination of racism?
That's a big one in terms of the critical nature, the complexity of racism work. I think we're talking about, some people use the concept of disrupting the system as we know it. But I want to talk about moving upstream. Well, because when we move upstream, we begin to see those issues that are underneath. When you think about the iceberg model I showed you, there are issues that are deep, the values, the ideologies that drives the intervention and action we see above. I believe that the system needs that upstream look in order for us to begin to address it. I am hopeful that while the system was constructed in this way, people are now talking about EDI policies and are open to discussing ways we can reconstruct this system by understanding how deep these issues are.
Thank you for that response, Josephine. There's a couple of questions about kind of the free anti-racism course. Maybe we can get a response later, but there's one question here from Stephanie Gilbert. Question for our incredible keynote speaker. Can you assist nurses with understanding how to respond to individuals who question if DEI initiatives are helpful or fair or effective?
I think that EDI policies and interventions are a good starting point. It's better than not having any program, but it's the beginning point for us to have those critical dialogue that will lead us to refine them and make them better. So I think that, again, those nurses or people who are questioning the EDI policies, we need to talk about how can we have accountability measures to see what's working in the EDI policies and what we need to change, because we can refine it. You start somewhere, and like any of our nursing work, we begin to refine it as we have more evidence to inform that work. So if we're doing all of the accountability measures, and we should be able to refine some of these programs. I will not say stop EDI programs, because we need to start somewhere. Yeah.
Great, thanks, Josephine. We have still 7 minutes left. I'll get through as many as I can, but there's lots of questions for you, so you might be responding after the session, but I'll keep going. There's Shani Sarah. Oh, I think Sarah. Hello there. I'm an educator in the College of Nursing, and I'm a person of color. Do you have any advice when you are faced with the wall of microaggressions difference when everyone speaks about anti-racism, but the education system, particularly a lot of nursing faculty, benefit from privilege? I find often that silencing is common and our students do not get the education they deserve. The educators frame it as a student-centered learning experience and to not make students uncomfortable.
Interesting when we begin to talk about the issues of people not being made to be uncomfortable, because what we're talking about is actually racism makes people sick. It's harming some people. People are dying because of it. And we talk about discomfort in that context. I think that, yes, as I understand where you're coming from completely, as a racialized or a Black faculty member, like what I said is quite often we don't talk about that difficult part of how you work with your colleague that's racialized. It's easier for us. In my research, I found that when I talk to people about racism or even about equity and diversity, they want to talk about the patient interaction. Bring it to talking about your colleague next door that you've never given those favors that you would give to your white colleagues, that you would have parties at your place and never invite. They can work with you for the last 20 years. You've never invited them over. They've never been included in anything. If you hear about scholarship or travel grant to go to that conference, you've never told them. You would tell those you reserve your favors for. Those things, they are also part of the structural racism we're talking about. And so how do you address it to answer this question? Again, I think we take each of these issues as teachable moments. It's very difficult sometimes to be you, the person experiencing it, trying to teach this. But how can we continue and stay focused, even with the piece we're working on, so that other people become allies? Sometimes when you want to do this work, it's building enough momentum around you that you have enough allies to move for the change. You can't move to do that change alone because, like, is it Lowen's theory of change? You need to create a disequilibrium and discomfort. So when people tell me they are uncomfortable, I say, good, it looks like something is happening, because it is the discomfort that brings about change. And so if you create your allies with those who are prepared to walk and talk and do this work, you will get to the point that those that are uncomfortable will be ready for the change, and then change can happen.
Great. Thanks so much, Josephine. There's one that's sort of similar to this. It's from a Gurjeet Kaur Tour. She says, how would you advise racialized leaders who are constantly coaching white leaders to take risks in this space?
I think the allyship presentation would help us to really look at what is allyship. Do you take center stage now, and the racialized person that's been doing that work stands and watch, or do you actually move the people who have been dealing with this issue to the center, and you become a resource and support for that? And I think that's what we need to ask ourselves. Where are the allies positioning themselves? Is it possible that you are an ally, but when it comes to speaking about the issues, you take the center stage, and the people who've been living with the issue go to the corner room to talk about their work? One of the things one of my graduate students again pointed out to me, and I've noticed this over the years, we go to conferences when you're talking about these issues. The racialized person presentation is the last one on Friday evening when everyone is gone, or in a corner room where nobody can find that room. And still, the ally who is speaking about that issue may have the center stage in the biggest room, in the prime time, around lunchtime where everyone can hear them. And then when you start looking at this, you say, oh my goodness, what is going on? And I've had this conversation, I think 20 years ago, with colleagues in PhD program. And then they go and look at our class presentation, and I was the last presenter, and one of my colleagues said, no, I'm taking that spot, because we've had these issues. But you still see it in many conferences. Who is getting the center stage, even when the conference is talking about equity and diversity? So we need to think about that as a profession.
Wonderful. Thanks, Josephine. So there might be
Okay.
one more here that I'm seeing there's some questions from our nursing student body. So I'm going to pick one, Dalia Hassan. It says, relating to your point about examining racism and health disparities as an interrelationship with health and social conditions rather than a distinct entity, can you speak on how and why interprofessional collaboration across all health professions is critical to advancing anti-racism? As a third-year nursing student at the University of Saskatchewan, I am recognizing that this work is often done in silos in our institutions, and there's similar questions like that about some of the lateral violence or horizontal violence or vertical, just based on some of the inequities across the different professions as well. And what's your
Okay.
approach on that?
Yes. I can't overemphasize the need for interdisciplinary collaboration because we all bring different expertise to bear. When we pick a particular issue, there are areas that we may not have the expertise. And so I think I really encourage us to look at interdisciplinarity as an approach. I really feel that nursing needs to understand its role at that interdisciplinary table. So we don't get in there and nursing is lost. If nursing is leading work, they need to see that leadership role because nurses will make up such a significant portion of the health workforce around the world globally. And when we are leading work, we need to be at the table and lead that work, but we bring in other people. In all my projects, I have interdisciplinary teams. Bringing people, I work with social workers, I work with people from the Faculty of Medicine, psychology, we come together, the interdisciplinary team for Black Health at the University of Ottawa. I lead the scientific arm of that center, one of the first centers that was created, focusing on Black health after the pandemic or during the pandemic. And I can't overemphasize the need for us to look at that. I couldn't believe one of my colleagues right now is working on a proposal on cancer. And we're just looking at the psychology of cancer. And that's a whole, like the lens through which she brings in ideas and how I'll bring in the nursing piece and then the sociology of cancer itself. And just positioning this different argument. Our colleagues from the medical school, we bring all of these pieces together and we have a role to play in nursing. Yeah.
Great. So there are some other questions, but we are moving towards the break because we do have speakers
Okay.
arriving at 1:30. So we will now be taking, so first of all, again, Dr. Etowa, thank you for this incredible presentation and responding to the very thought-provoking questions by the attendees. And we'll definitely continue the conversation and the dialogue and make sure that for some of the content-specific requests that maybe you're just looking for some further information, that we get that information to you. So we'll be taking a 15-minute break, returning at 1:30 to hear from the acclaimed podcast host, the Gritty Nurses. I would like also to remind everyone that we will be recording and posting the sessions to the CNA website in the near future. We had mentioned that at the start of the session, so I know everybody is really wanting to get access to Dr. Etowa's incredible presentation, and you will have access to it. So thank you, everybody, and have a good break.
Thank you.